This conference will now be recorded.
Hello, everybody. I appreciate you taking some time to join us to go over some things that are near and dear to my heart. My name is Brad Bernardini. I'm one of the orthopedic sports medicine surgeons with Reconstructive Orthopedics. And as I mentioned, ACL injuries and reconstruction are an integral part of my practice. I spend a lot of my office time and surgical time with ACL injury management. Um, we've also become with prevention side and the post-surgical or rehab and performance enhancement side. I'm a co-founder of a entity called the Energy Lab that is integrated with our medical practice. That is really a medical partner to our physical therapy in order to help prevent injury and return to play with some evidence-based science behind it. And so ACL injury is a big part of the impetus for that creation of that entity. So I'll briefly talk about it at the end, but we've got a lot of stuff to cover. So just kind of wanted to go over some education objectives pretty much. We're very briefly going to talk about anatomy and function. The real purpose of this talk was to really get to the nitty and gritty about some of the things that are coming to light recently with regard to some of the literature that we have about how good of a job are we doing with ACL surgery? What do the return to play numbers look like? What happens if people don't have surgery, if they have ongoing instability events because the ACL is not working well? And that's really the big kind of meat and potatoes of this talk. So I'm not going to spend a ton of time on the front side. Functional anatomy, just briefly, the ACL is one of the four major stabilizing ligaments in the knee, and we generally consider it to be the most important. It's got two major parts. So if you look at this picture down here, you've got these two arrows, and those two arrows and those initials point to what we consider two separate functional parts of the ACL. One of them controls straight translation of the shin bone on the thigh bone, and it prevents that from happening excessively. And the other prevents rotation of the shin bone on the thigh bone. And those are both important things that the ACL prevents from happening too excessively. If one of those bundles is damaged, it can lead to a complete loss of function for that respective role. So while there are such thing as a partial ACL tear, it typically is a one bundle tear, and that's still something that we think is important to address. So often we hear partial injury, and most people kind of say, oh, that's great, I only have a partial tear. But in the ACL situation, it's not necessarily the case. The way most people know they have an ACL tear is that they feel this slipping or this looseness. People describe my knee buckling out or giving way, or I went to twist to change direction and it shifted underneath of me. That motion over time is the thing that actually leads to all the damage. In the short term, it's kind of an annoyance that people have that feeling, but in the long term, the other structures in the knee that weren't really designed to handle that extra motion start to get broken down. And the two major structures that we see break down are the cartilage, and cartilage damage leads to arthritis, and something called the meniscus, which is a flexible type of cushion in the joint, but it also helps with stability. And those are working overtime. And so we see an increased rate of meniscus damage, about 20 to 30% risk within, sometimes a single episode of instability. But over about 4 to 5 years, is about a 30% risk of meniscus tears. And advanced arthritis, about 87% risk of advanced arthritis occurring within about 8 to 10 years of an ACL tear if it's not fixed. And that's versus about 20% in the general population. So that's overall a pretty significant increase. Those are the reasons that we think the ACL is important. The mechanism of the injury is been really well looked at, and it's actually been studied on some video footage of injuries. And about 70% of these are non-contact, which means that the only thing involved is the patient and the ground. And we see this a lot clearly in sports, but we see it from other activities of daily living, laborers, people just doing everyday things. And it's typically a slowing down with an attempt to change in direction where you're a little off balance, and it's usually a plant on one foot. And there's a concept of something called the provocative position. And the provocative position really is where there are certain factors that aren't taking advantage of the full force absorption mechanisms that our body was meant to have. So our body's meant to handle certain forces to a certain degree. And there's certain positions that certain people get into that aren't optimizing that natural mechanism. And it usually involves a foot out in front of you where you're landing on your heel instead of landing straighter than it should on your toes, so you can kind of absorb that force. The knee would be usually almost fully straight, and it's typically a little bit of an off balance position with a kind of a knock knee. And that is a position where the ACL ligament gets overloaded and it can't hold on anymore, and it ruptures. The other concept that's come to light is the at-risk athlete. Again, this doesn't just happen to athletes, but we commonly refer to this as an athletic injury. The at-risk athlete is a combination of both anatomic and what we call neuromuscular, and you can think of that as functional deficits, as well as actually potentially hormonal factors that can play a role in increasing the risk in certain patients. And unfortunately, these factors are present to a much greater degree in females. And there's a lot of studies that show that females are about a 4 to 8 times greater risk of an ACL tear compared to a male their age. And we see this most notably in adolescents. And that's really the huge population that we see, that I see in my practice. A lot of high school athletes, soccer, basketball, volleyball, where we have these pivoting activities that put people at risk for that provocative position and the mechanism that we discussed. And the reason it's important to know those things is the provocative position can be taught. And if you educate athletes on that position, we can avoid it. And there's factors that we can kind of modify. And even with the at-risk athlete, we can't necessarily modify the anatomic factors without surgery, but we can modify some of the functional strength and the neuromuscular conditions that we see. So the diagnosis is actually pretty common to be able to be made without an exam and without an MRI. There was a study done that showed that there are 3 common factors in the history of someone that injures their ACL. And one is an off-balance twisting injury associated with a pop. So most people come in and say, I was twisting, I was starting to lose my balance, and I felt a pop in my knee, and they go down. The second is that they aren't able to get back up and continue whatever activity they were taking part in before. They can't walk off the field under their own power. And the third is that the knee almost immediately swells. And what that actually is the ACL has a good blood supply. When it tears, it bleeds inside the knee, and that bleeding causes almost immediate and significant swelling. So if you have those 3 factors in your history, it's been shown that you're about an 85% likelihood of having an ACL tear based just on those factors. So a lot of times I'll just listen to a history in the office and have about an 85% chance knowing, that this potentially is an ACL tear. What we generally recommend is that if you think this may have happened and you haven't gotten to a medical professional yet, do not try to walk on it, because every little episode where the knee can give way can cause more damage, like we talked about. Gentle motion's okay. A lot of people think they have to be rigidly straight, and that's not the case. And we recommend that you see a specialist. Unfortunately, there are times that we see people who have gone to an ER or an urgent care center where they didn't see an orthopedic specialist, and they have been potentially misdiagnosed as something less than an ACL tear, and maybe they didn't take the injury as seriously, and there's a delay in diagnosis, and we'd like to avoid that. So to confirm the diagnosis, again, in addition to the history, there are very specific physical exam tests that we can do, and those give us about a 95 to 98% likelihood of confirming the diagnosis just on the exam. And we do those in an office. Again, they're best done by a specialist. Additionally, we usually get x-rays to confirm that there's no bone damage, and then an MRI to really look at the things that the x-ray doesn't show. So x-rays just show bone and calcified tissues, whereas an MRI shows everything else. So this is an example in front of you of an MRI. We're basically looking at the side of the knee. Here's a kneecap and the back of the knee. The ACL is this strong band that is running from the thigh bone, which is up top, to the shin bone, which is on the bottom. And that red is kind of lying over this black, straight ACL structure. The one on this side is an example of a tear. So in a tear, you can see this edge of these kind of stringy bands that just look like they end. Typically, that's a nice dark band that comes all the way up to the other side. So this is an example of what an ACL tear looks like. So once we diagnose the injury, it's time to start talking about treatment options. And this is where we start to get into some of the there are some popular concepts with regard to ACL management. There are a subpopulation of people that can be treated non-operatively. Those are generally on the middle-aged to older side. I'm sorry to be in that group now, but you know, we start to get written off a little bit. Maybe people who don't have a high level of activity, they're not participating in competitive or recreational sports at a high level. They're not playing pivoting sports, and maybe they just had you know, an unfortunate injury that occurred from an everyday activity. Those people, we can potentially rehab and get strong and teach how to avoid those instability episodes so that they don't have any issues. Unfortunately, most of those have not been able to return to a high level of function, and most end up, with regard to activity, being you know, cyclists, swimmers, and inline, what we call inline sports. Most people that I see in my practice are going to end up with an operative intervention, because most of them are athletes to start with, and they have an intention to get back to those high level sports. So the things we have to talk about with operative intervention are surgical risks. You know, in general, there's about a 0.5% risk of infection. There are some risks of anesthesia complications. There are some risks with swelling and blood clots in the leg. Those are all things that we have to take into consideration. Surgery, even one like this, which we do relatively routinely, has some significant risk, and we have to be serious about that. Estimated time for rehab and recovery has been something that's really been looked at very closely. I'm going to talk a little bit more about that, but the reality is that the graft, which is what we use to reconstruct the ligament, and I'll talk about that, takes about 3 months to heal, takes another 6 to 8 weeks to what we call remodel. And so it's about 5 months before it's actually strong enough to start really working on doing physical activity. It's been shown to take potentially up to 18 months to actually mature. And that's really significant with regard to rehab and when we can expect to get back to things. So that timeline has gone longer the more we understand about ACL reconstruction. We used to try to get people back to activity at 6 months, and we realized that those had a high re-injury rate, potentially about 30% at that point. What are re-injury rates now? If we do a really good job and we follow the recommendations for timing to return to sport, it's about a 6 to 7% re-injury rate on the operative side. So the ACL that was fixed has about a 6 to 7% re-injury rate, and the non-operative side actually has about a 5 to 6% re-injury rate. Now, it's interesting, there's some studies that show that if you work on a diligent post-op return to play program and you focus on the operative leg after an ACL reconstruction, that there may actually be an increased risk in the opposite leg. So it's important, we always emphasize to our patients to don't forget about your other leg, because there's a risk of that. And unfortunately, we do see that happen. Return to sports is something else that's really been looked at lately. And the return to sport rates are actually a little bit glass half empty these days. It's been shown that in competitive sports, only about 55% of athletes can get back to that level of competitive or elite sports, which is not a great number. And all comers, recreational athletes, it's a higher number, but competitive or elite athletes, and that's D1, college, into pro, semi-pro, have a poor return to sport rate. And there's a number of reasons. They're not just physical, and those don't necessarily involve re-injured ACL grafts. They just involve patient factors, confidence factors, failure of getting full strength back, and there's a whole complex list of things. Surgical reconstruction is, in these modern eras, about an hour procedure. Fairly often it's much less than that. It is outpatient and arthroscopic. So that means we make little poke holes generally. If we're harvesting a graft from the patient, there may be a bigger incision, and I'll talk about that in the next point. Nerve blocks, which historically have been done to help with postoperative pain, make the leg numb, those have been a little bit controversial. They're not necessarily shown to be associated with better outcomes, and in some cases, they've been shown to cause a delayed return of quad muscle function. So those are not necessarily advocated for. There are some newer type blocks that don't have that same effect, but generally, we have our patients go to sleep for the procedure, so it is general anesthesia. Graft choice is a really important issue these days, and this is something that is important for especially younger patients to be aware of, and their parents. Young patients, we're saying under 25, it's been shown that it's best to use what we call an autograft. An autograft denotes that source of the graft, basically what we use to reconstruct the ligament, comes from the patient. And there's three common sources for that. BTB refers to bone, tendon, bone. Hamstring and quad, they're all kind of variants of tendon tissue from the body. And it's been shown that they, in general, don't leave you with any significant side effects. There are some subtle things that we could get into if we had to have a real detailed discussion, but in general, the body tolerates that well. And those are much better choice in younger people because they don't show a increased rate of loosening versus what we call allograft tissue. Allograft comes from a donor, typically a tissue bank. And in people under 25, allograft tissue has been shown to cause or result in loosening up to 25% of cases. So whenever possible, we like to use autograft in young patients. Anybody over 25, either source has fairly similar outcomes. Again, we talked about the healing time. I think we went over some of this. 3 months of healing, 5 months to remodel, 9 to 12 months potentially return to sports. Physical therapy has been really a major focus of some of the newer studies. There are accelerated protocols, non-accelerated protocols. In general, what we've found is that therapy is usually taken advantage of for the first 3 months. It's very common that at that point, the insurance companies aren't necessarily allowing patients to continue. But we found that it really is critical to have some sort of oversight or guidance for at least 6 months, potentially more, which again is one of the reasons that we've developed our medically integrated sports performance center to address that deficiency that we found. This is an example of just kind of general schematic of what a hamstring tendon autograft would look like. So this is thigh bone, shin bone, and the hamstrings, we all know, are the muscles that are deep in the back of our knee. Well, there's a group of 3 tendons that wrap around the front inside part of the knee, and we can actually access 2 of those pretty easily through a little incision, maybe 3 centimeters, centered right over the front of the shin bone. And we can actually harvest that graft, and then we use those 2, we loop them over so it's actually ends up with being 4 strands of the graft. And then what we do is we kind of pull that through into these little bone sockets that we create inside the knee. We do that arthroscopically through little poke holes, and we anchor it in place. And there's different ways to anchor it in place. Again, this is just a schematic showing screws. We don't typically use as many screws as we used to. We don't use as much metal as we used to. A lot of times now we're using resorbable tissue anchors, or we're using surgical grade plastics that don't show up on x-rays and allow us to get MRIs in the future without difficulty. And basically what we do is we anchor it in place during surgery, and then we start the clock on the healing response. Again, these are some of the kind of downsides of the ACL injury. Return to play, 81% return to any type of sport, 65 return to pre-injury level, and then only 55 return to competitive or elite sports. This is really hard for athletes to hear. The highest re-rupture rates and failure rates in ACL reconstruction surgery are actually in younger athletes that have a higher activity level, and that makes sense. The younger you are, the greater the risk is with having poor control of your body and having some of these risk factors that we talked about in the beginning. And the higher activity level, the more demand, the more stress, the more likely you're going to end up in that provocative position for the knee. And so we see those rates being higher than that 6 to 7%. Sometimes they're up to 25%. And that's kind of a scary number. And again, 5 times greater risk with allograft tissue in patients younger than 25, and 5 to 8 times greater risk in female athletes. Those are some important things to know. So one of the things that we've become much more focused on at Recon Sports and within our group is how do we change some of these risk factors and how do we prevent injury? There are some really good studies out there that are now showing that we can actually decrease the likelihood of an ACL injury up to potentially 74% in certain populations, most notably adolescent aged females. And it can be done as 8 weeks of a conditioning program or neuromuscular training program, where we basically educate the athlete on these risk factors for injury. How do you prevent your knee from getting in that bad provocative position? How do you train your muscles to absorb force better? How do you make sure that your balance is better? How do you keep your body centered over your foot? All those things are part of the education process and the training process that we use our clinical staff to help get across. If we can train that and work on repetition with good technique, about 8 weeks of that has been shown to have long-lasting effect on injury prevention. We like to then send people out into the world with a better education of how to maintain that on their own, but they're always free to come back to us and work with us. We've really made this into a formal facility at the Energy Lab. Again, that's our medically integrated sports performance center. Currently, our facility is located in Pittman, adjacent to our orthopedic office in a facility called the Total Turf. It's a big sports complex there in Pittman off Lambs Road. If you're interested, you can look us up online or Instagram, social media, Facebook. And basically what we do there is we try to work on prevention programs for healthy athletes. And we also try to share that same injury prevention education with post-operative, post-physical therapy athletes that have already gone through the surgery so that they don't re-injure their operative side and so that they don't have a likelihood or as great a likelihood of injuring their opposite side that they aren't post-operative for. And again, up to potentially 88% reductions in injury. And it's all based on these neuromuscular programs that we have learned are factors that we can modify. These are just some pictures from our facility in Pittman. And that's our Instagram tag, _Energy Lab, if you're interested. I am happy to address questions now. I wanted to get through, the big picture things and some of the newer kind of literature-based findings with ACL injury prevention and surgery. So hopefully I answered a lot of kind of glaring questions, but if there are any other detailed questions, I'm happy to take those now. And if anybody looks at this after it's been archived, we are happy to field questions, and you can get to us through our website and the patient portal.
Thank you, Dr. Bernardini. As Dr. Bernardini just said, if anybody has any questions for Dr. Bernardini, please feel free to unmute yourself, as long as we have one person speaking at a time.
It must have been that good.
It was very informative.
Oh, no, there's somebody coming. No, they went away. Good.
I have a question.
Oh, yeah, go for it.
So would it matter? I tore my ACL and have never had it repaired, and it's old. I'm older, and I'm looking at like 20 years ago. Is there a window of opportunity that I've missed to have it repaired?
It's interesting question, because we have seen patients who have been reasonable copers. So you're considered what we call a coper, somebody that can cope with the injury, and apparently have done okay. If you've made it this long, I imagine that you haven't had a significant impact on your quality of life. But the short answer is no. There isn't an absolute time limit. The longer answer would probably be what other damage has occurred in that time. And there is a certain point where a patient develops a certain degree of arthritis within the joint, a certain degree of deformity within the joint that precludes us from being able to in good conscience, do an ACL reconstruction, because what we're doing is trying to prevent arthritis. So if you've already got arthritis, the point of doing an ACL reconstruction is questionable. If you had significant instability events and you felt your knee shifting, popping, giving out, that would potentially be a reason that we could do it. And we have done that. We have seen people who have dealt with it fairly well and maybe took up a new activity or hobby, and now all of a sudden they feel unstable and they have a delayed ACL reconstruction. But there's a lot of individual factors about the status of your knee that we'd have to be able to look at to determine if you're a good candidate still.
Thank you.
Yeah.
Good question. Was there anybody else? All right. Well, if that the questions, Dr. Bernardini, again for your time tonight. Thank you everybody for joining us. And we will go ahead and stop this recording and it'll be posted onto our website next week. Thank you again.